Today we're at the Milpark Gamma Knife unit to discuss acoustic neuroma management, and with me I've got our ENT specialist, Dr Ashen Nanan, and our neurosurgeon, Professor John Ouma. Dr Nanan, I'd just like to start off with the term acoustic neuroma, because that is an outdated term, isn't it?
Yes, Gavin. So that is a bit outdated, and currently the technical name for it would be a vestibular schwannoma.
Many of us were not paying too much attention to acoustic neuromas, vestibular schwannomas, when we were in our undergrad. So maybe you can just quickly take us through what are the key issues that one should be looking for in patients?
Yes, so this is an area that dominantly is seen by ENT specialists and audiologists. So the early detection of these tumors is extremely important, and generally these patients would present with an asymmetrical sensory hearing loss. It may or may not be associated with vertigo, and one may also have other cranial nerve fallout, and this would include the facial nerve resulting in paralysis of the face, the trigeminal nerve, which may result in paresthesia or sometimes even early pain in the face, and the lateral rectus palsy with the sixth nerve involvement, because these are the adjacent nerves to the eighth nerve.
Great. Once we've made a diagnosis of a vestibular schwannoma, what are the key management techniques that are available to us?
Yeah, so in fact, what I forgot to mention to you is once there's a suspicion of a vestibular schwannoma, the gold standard is to do an MRI scan with gadolinium, which is the contrast that helps us to pick up even small tumors. And there are different modalities that one can manage this with. In smaller tumors, one would usually watch, wait and see as the principle, and do serial MRIs, usually annually, to monitor the growth. And it's usually when these tumors become symptomatic that one needs to intervene. There are modalities such as Avastin therapy, which is a drug which certainly slows down the growth of these tumors. If there is significant mass effect from these tumors, one can resort to surgical intervention where these tumors are resected. And what is very nice these days is that these patients then don't need to lose their hearing completely. We are able to rehabilitate this hearing primarily with an auditory brainstem implant, which we place at the same time. We have also gotten extremely good results with gamma knife therapy in patients in reducing and slowing down the growth of these tumors.
That's good to hear that patients with vestibular schwannomas can be offered a treatment modality that is suitable to their tumor. So, Professor Ouma, can you maybe just explain to the audience out there, what is a gamma knife?
So gamma knife, well, that's a second misnomer on this talk. A gamma knife is not a knife in the true sense of the term, but because it employs stereotactic fine point radiation surgery, it is akin to a knife in terms of the precision with which the technology is applied to the tumor. So one arrives at this facility and a very high beam of focused radiation is applied to the lesion, in this case the vestibular schwannoma. So that is the reason why we call it a knife, because it's similar to a knife in the way it functions.
And am I correct that typically we're looking for patients with a tumor that is smaller than 3 centimeters?
Correct. So for technical reasons, the size of the tumor is important, and 3 centimeters is a magic number. The tumors, vestibular schwannomas that are up to 3 centimeters or less would be the ideal candidates for this technology. However, there is one rider. For patients who are syndromic, and by this I'm referring to neurofibromatosis type 2, we exclude those patients because there is a concern about the potential for patients with NF2, all their tumors, including the vestibular schwannomas, to become malignant. And there's also that slight concern, which I must say is really, in my view, unfounded, that the gamma knife can also perhaps partly contribute to that. So for that reason, really out of an abundance of caution, we exclude syndromic patients. But for everybody else with a sporadic vestibular schwannoma up to 3 centimeters, that is the candidate we are looking for.
And if we bring a patient into the Gamma Knife with a vestibular schwannoma, what sort of clinical outcomes can we expect?
So the outcomes I would look at them in two terms. One, the outcomes in terms of the symptoms with which the patient presents. And these are mainly, the vertigo, instability. They may have a degree of hearing loss, they may have a degree of facial palsy, and perhaps even facial pain. And in all those respects, a patient arriving for Gamma Knife can expect significant improvement in those symptoms. So the patient, for instance, who arrives and says, my face is, I'm all wobbly and the room is spinning around me, which is the most troubling symptom that they have in the first place. Many of these patients after treatment will in fact feel much better. But the other aspect of the expectation is what happens after the treatment. Now in many surgical series, patients may end up with worse symptoms in certain regards. So Gamma Knife is unique in terms of the fact that the complications that one can expect or that one sees are very minimal. For instance, hearing is usually preserved, and one can say that for surgery. Facial nerve function is usually preserved, one can say that for surgery. Additional things like trigeminal syndromes and so on, which may follow surgery, are not common after Gamma Knife. So in both respects, resolution of the pre-treatment symptoms and non-development of serious treatment complications, excellent results from Gamma Knife.
So what we've been given is a snapshot as to how the Gamma Knife can help patients who are appropriately selected. At Gamma Knife, what we've done is we've put together an evidence-based review, and our evidence-based review is available at our website, which we hope will give you many resources in order to interact with your patients. The problem with looking at evidence-based medicine in surgery is the interventions change over time, and we have very carefully selected the evidence and made sure that the evidence is reflective over that period of time. And why is time important? Because many of the complications take time to develop. So we would welcome you to come to the Gamma Knife website and access the information that would be useful to you.